and we talked about it a little bit, the difference between the studies with alectinib and ALK with having the same therapy on the adjuvant side. What are you all's thoughts on why you would continue with adjuvant immunotherapy? And I think we're alluding to it kind of, right now with our discussion on the previous question. In a patient that received neoadjuvant prior to resection immunotherapy plus chemotherapy, had their resection and achieved a pathologic, complete response. What are the thoughts on, continuing immunotherapy on the other side of that?
So I think what we've seen with the neoadjuvant studies, looking at CheckMate 816 and really all the trials, if you achieve a pathologic complete response with immunotherapy and chemotherapy, that you do very well. And it's unclear how much the immunotherapy after surgery is contributing. Is it helping at all? Is it hurting at all? And there are studies that will answer that question. We don't have those. And what we need to do, what all of us do, is make decisions in the absence of data with extrapolation. And right now, if someone is having toxicity, there are cost issues, I think the use of immunotherapy after PAT-CR is probably less important. But where I would absolutely continue it, I think the PD-L1 negative group, they do consistently pretty poorly. And as long as someone's tolerating it, I'd rather give it. Two, if the patients are not comfortable stopping, I'm not comfortable stopping, because you mentioned humility before. I acknowledge that we don't really know the answer to this. And so we have a discussion with the patient. And so as long as it's not doing harm, I feel comfortable with it. Is it absolutely necessary? I don't think we really know the answer to that yet.
Yeah, I wish you could ask me this question in like 2 days, because we're going to hear an update from CheckMate 816, which is looking at neoadjuvant chemoimmunotherapy, the only regimen that we have right now that's FDA approved in that setting, that's neoadjuvant only. And we're going to hear about an overall survival update, right? So I'm curious if we're going to be able to see if patients achieve PCR, what is that true benefit of overall survival? If it's really, really beneficial, I may actually talk to my patients and show them the curves and say, hey, listen, like, I don't really know. I'm not convinced enough if we need to continue it. So maybe I can answer that question better for you, Sanjay, in like 2 days.
Love it. Yeah, and then, not to throw a wrench in the box entirely, but I kind of want to. We're talking about path-CR, and what we might be talking about tomorrow is a ultra-sensitive circulating tumor DNA response, right? Because a path-CR is a pathologic under the microscope. Okay, I can't see any tissue, but I think we had an update today that we're actually going to discuss later. What about, the subsets where you think you got it all, but then you actually have positivity of circulating tumor DNA versus it being cleared? Because we don't want to have these lump conclusions that actually there's a cohort that ends up benefiting or not benefiting. And I think the more clarity we have on a persistent disease setting, I think, and who knows, even that's yet, to be fully determined based on disease type, is yet to be told. It's a humbling field. I think we're going to keep circling back to that.